When you're trying to decide whether a patient should be recommended to stop therapy, the most critical factor that's emerged, particularly for patients on imatinib therapy, is the duration of the deep response. And apparently less important is the duration of the kinase inhibitor therapy overall. This is based on the EuroSki study, where they analysed separately the duration of MR4 and the duration of TKI before patients achieved MR4. And they demonstrated that by far the most important predictor is the duration of MR4. So that if you've had about 3 years of MR4, then you have a success rate of about 50%. And for each year of longer duration of MR4, you improve that by about 3%. That's a very useful equation to use for your patients who are considering stopping. It still doesn't leave you with great certainty. You're still left with a situation where it's around about a 50% chance, or in some cases a 60% chance of success. So it's by no means a guarantee, but it's much better guidance than we had before. In the second line setting, it's not quite so clear-cut in terms of the predictors, but we do know that the reasons why patients switch from their first line to their second line will have some impact on the success of the attempted stopping. So if you switched from imatinib to nilotinib or dasatinib because of intolerance, and you then achieve a deep response, your chance of success are excellent. If you switch because you've failed imatinib therapy, then the results are somewhat more mixed once you achieve a deep response on your second line therapy. The ENESTop study suggests that results are pretty good, but some of the other studies would suggest that they're not as good. So I think we need to be a little bit more cautious about that group of patients. It may well depend on the nature of the response to imatinib, so that patients who just fail to achieve targets may be perfectly acceptable candidates, whereas patients who have frank resistance to imatinib and then switch to nilotinib or dasatinib may be more problematic. What we've learned from the ENESTFreedom study and from the equivalent dasatinib studies is if you start front line with a second generation drug, not only will more patients achieve deeper response more rapidly, but you'll get to a point of potential eligibility for treatment-free remission considerably earlier than you would get if you started with imatinib. And furthermore, the ENESTFreedom study shows very clearly that whereas patients have had a median follow-up of only about 3 years, the success rate is equivalent to the success rate we saw in imatinib studies, where the median duration of drug was more like 7 or 8 years, so that you can get to that point and succeed at a much earlier time point, which is an important message, particularly for young people, for young females who are considering having a family. The most rapid pathway to treatment-free remission would be a second-generation drug up front.